see if this works. Yeah. I was pleased with that because I just put those action buttons in this morning before breakfast. Of course, I should have done them another time. A couple of years ago, Department of Health in England came up with a proposal to measure the wider societal benefit. So, Department of Health are big supporters of cost per QALY, but there's a recognition that maybe the QALY is only capturing some part of the benefit of healthcare interventions, and there are wider societal benefits. And for Department of Health's purposes, they've defined wider societal benefit as the difference between production and consumption. And so you could call it perhaps net resource impact, but production and consumption. So the idea is this: patients, if you don't intervene, will have a particular level of production. It may be zero, of course. They're unable to work. If you intervene, you will change the expected production. Now, it's important here to stress that production is not being viewed narrowly as only paid labour. It's recognising that people also produce value through unpaid labour, most obviously in the household, but also through voluntary activities as well. So, excuse me, it's a broad notion of production. Okay, perhaps it's predominantly paid labour market activity, but it's also going to include unpaid labour. And the idea being that if we can make improve the patient's health, their production should increase. Patients are not only potential producers or actual producers, they are also consuming resources. They consume most obviously formal health care, but they also have informal care. They consume government services. There's a list of things they consume. And so the idea being, if we return a patient to health, not only will we have an impact on their production, we'll probably have an impact on their consumption. And particularly, formal care will go down. And maybe the consumption of other government services might go down. And informal care might go down as well, because one of the biggest sources of care for sick people is informal, family, neighbours, friends. And so perhaps you begin to get the idea here. The QALY, it's looking at survival, change of health state, doesn't capture any of this really. There's wider societal benefits that are missing, and they could be summarised through this difference between production and consumption. Now, to operationalise it, they developed simple models that looked at 4 different characteristics: the age of the patient, the gender, the ICD code, in other words, which disease area was involved, and the final one, represented here by Q, quality of life. And so, for example, and I won't go through it blow by blow, they argued the amount of formal care consumed by the patient was particularly driven by their age and their health state or quality of life. Their labour market activity was largely explained by age, gender, and again the quality of life. So this, to some extent, was addressing the issue that you were raising, that, well, if we now look at somebody who's very ill, and we might move them from point 1 to point 2, actually, we probably won't change their consumption, we won't change their production. So there's no additional benefit from treating them. But if instead we have a patient who's at point 8 and we move them to point 9, that is quite likely to affect possibly paid labour, possibly unpaid labour, and also may lead to reduction in some of these areas of consumption. And so the Department of Health, you'll be glad to know in England, was thinking along the lines that you were suggesting, that actually weight in QALYs and by severity, that's one thing, but there's something missing. And these are best captured by this net resource impact. Subsequently, we didn't change our system. We had a consultation on it, and there were very mixed views. Basically, for many years, patients had been saying, it's terrible that we aren't really including informal care and things like that. But then this came as a package, and patient groups got a bit scared of the idea that whether somebody worked or not might be influential in whether or not a treatment was going to be available. Now, it wasn't that we'll treat you if you work, but it was more people with your type of condition, if we treat you, will we typically see increased production, increased work, or will we not see increased work? So it wasn't personalised to individuals, it was to the patient group. And so while patient groups had been quite active wanting to go beyond the QALY and to try and capture wider benefits, things like the care that informal carers were giving, and if you could reduce that, that's a benefit. While they liked that element, they didn't like the focus on paid labour. Right. Actually, I've covered cost effectiveness and affordability as we went along.